Good evening, everybody, and welcome to our 12th and last webinar for this 6 weeks program. Don't worry, this is not the end. We are going to keep you on our databases, and there will be little bits of events happening over the next few months. But tonight is officially our last webinar, and we are very pleased to be ending with a mental health topic and to actually have a psychiatrist with us this evening. So a big welcome to Professor Leslie Robertson, who is currently jointly appointed as the head of unit psychiatrist at the Sedibeng district specialist mental health team in the Gauteng province. And she's also an adjunct professor in the Department of Psychiatry at the University of Wits. She advocates for accessible mental health services with a focus on patient-centered, community-based psychiatry and primary mental health care, which we're very excited about at RUDASA. She's a member of the National Essential Medicines List and the PHC-Adult Hospital Expert Review Committees in the Essential Medicines Program. She's also served on the expert panel for the investigation by the Health Ombud regarding the Life Esidimeni tragedy in 2016, and on the Section 11 Committee for the South African Human Rights Commission investigative hearing into the status of mental health care in South Africa in 2017. And her research interests are in mental health systems and quality of care. And I think as RUDASA as well, mental health has been one of those priority areas that we've been prioritizing because we've noticed that it doesn't seem to get prioritized anywhere else. So we are very grateful to have Prof Robertson with us today, who's looking specifically at the aggressive or distressed or psychotic patient in your rural health facility, but I'm sure she's going to look at it in a little bit of a wider context as well. So thank you very much, Prof, and I hand over to you.
Thank you very much, Madeline. Thanks a lot. So I'm going to just share now. Okay. So, okay, so you can see, let me just put that onto the wide screen. So hi, everybody, and I'm going to be speaking mostly to the standard treatment guidelines, which I think you probably all got internet links to, and I hope if you've got Android phones, you can download them as well on your phone. So I'd like to start, though, with the report that was on IOL in 2011. I'm not sure how many of you heard about this. I actually knew this young guy. He was a 6th-year student in my ward at Barra, and only a year later he was killed. He was doing his internship at Middelburg Hospital in Mpumalanga, and he was stabbed to death by a patient. So the story was that and the story the father got and gave to the journalists was that the patient, the man, said he had had an operation on his wrist in 2006. Now this is 2011 when this man came in. When he came in, he wanted to be seen by a doctor because he said doctors had left needles in his hand. My son referred him to the X-ray department to have his hand looked at. And when he came back with the X-ray, my son explained that the scan showed there were no needles in his hand and suggested he go to the orthopedic department. He said the man became angry and then left. My son had his back turned while he was working on the man's files. The man came back, and when my son turned around, he stabbed him in the hand. My son tried to ward him off, but the man stabbed him in the heart. And the man actually then ran and left the hospital, and on his way out, the security tried to stop him, and he injured one of the security guards on his way out. Now, I was talking about this at a congress shortly after this incident to another psychiatrist, a forensic psychiatrist, and he said he actually knew this patient. It was a forensic patient. He was a state patient who was on leave of absence. And so, you know, just highlights the situation that we're all in. So we have a practice, our policy in South Africa is as far as possible, everyone must be able to go home. We try not to keep state patients, involuntary users in hospital for lengthy periods of time. And what happened is while they're in hospital, they seem contained, they are cooperative, they're taking the medicines, and there's no justification for keeping them in hospital. So immediately, we discharge them, we do it on leave of absence, and then discharge them to be managed at primary care. Sometimes if they live close to one of the tertiary hospitals, they can be managed there as an outpatient. And that's when things change. So we do not know who we're treating. We don't know what they're coming in for. And they might not even seem to be aggressive. The other thoughts I had when I read this was anyone who's had hand surgery, you're going to start being suspicious of. Why did they get the injury in the first place? What happened? The next thing is some sort of delusion here about having needles left in his hand. How, and I don't want to victim blame here, but what could this young guy have done to save his life? In what could he have picked up? Could he have picked up anything? How could he have consoled the man? What could he have done to try and mitigate this anger that the guy had? Just of concern, the Nahawu spokesperson to the same journalist said 2 months previously, 2 nurses were attacked and a patient was killed at the same hospital. We have no idea if these were from psychiatric patients or if they were from people with personality issues and substance use or delirium, or if they were violent and criminal attacks. So by the end of this talk and this session, I hope that you'll be able to prepare your casualty or your ward or your unit staff where you're working to manage a person with aggressive or disruptive behavior, to de-escalate and contain such a person, to make an emergency assessment of them, to tranquilize and if necessary restrain, and to admit them under the Mental Health Care Act. So I'm going to be referring, this is just a screenshot of the pages in the STGs, and we can make these. This is something I've done for my district. I've basically taken out the STGs. I've adapted it very slightly so that it can be stapled together and put up as an SOP in all facilities. So this is the pre-hospital clinic management, which would go up in PHC facilities. And then the next one is the adult hospital, acute hospital management, would go in district hospital, regional hospital casualties, psych wards, medical wards, and wherever you think you might be getting such anybody with aggressive or disruptive behavior. It is a requirement from the Office for Health Standards Compliance that any ward which is caring for people with mental illness does have an SOP for aggressive disruptive behavior. So what you can do, this is in a Word document which I have made available to Madeleine. You can take it to your clinical managers in your hospitals. They can put the province that you're working in, and they can put the institution up here. If they need to, they can add a signature line at the bottom, and anything else that you feel you want to adapt, you can do. That is in the front matter of the STGs. But what I've got here is that it's been adapted. So you could leave that footer. That way you can use it in your, you could have it laminated and put up on the wall, or whatever you feel is useful. And I'm going to, some of the slides are screenshots of this. So just to start with, the first part of this is to prepare, anticipate, and prevent. And what we've said in the STG is to be aware of high-risk patients. Okay, so, and this is the problem, is you actually should know, or somebody in that unit needs to know, those who've got a history of previous violence, of substance use, and any state patients on leave of absence. And in the facility or your casualty or your ward is to have a stepwise protocol in place, to have clear roles for all staff members, a triage plan for early signs of aggression, available backup plan to hospital security and SAPS and EMS if you're in a clinic situation, and a designated calming area, which is suitable for regular monitoring. So just some thoughts on that is, first of all, it's the knowing. You've got to know who your team is. So when you go into work, don't just go in and do your job, but you go in, you find out who is your operational manager in your ward, who are the nursing staff. Nursing staff know unbelievable amounts of information, and they will know who your recurring patients are in the casualties. Know who the security guys are, even your admin clerks. So each time you move on your rotation, or in whichever unit you go to, try and find out who the team is that you're working with. And then find out if there is a protocol in place and what do you do in a situation, who is the backup security. Find out from your team what room is available should somebody be aggressive or disruptive. And has the room got exit points, more than one exit point? Okay. If it doesn't, you need to position yourself next to the door, and you preferably have the desk. So you put your desk so that your back is to the door and the patient's on the other side of the desk in the room. And you need to know your population. So that's quite difficult for us as doctors. We tend not to know. The people who know are usually the nursing staff who have been working there for years. So particularly your operational managers, facility managers, any long-term staff member, even admin clerks, because I know that one is always coming in here like this. And they need you need to have that communication set up, where if they see somebody coming in who they know has been violent before, that people are alerted. And then somebody in that unit should have the job of constantly scanning the waiting area. And the reason for that is you're looking for agitation or any verbal aggression, any fidgetiness, any impatient sort of gestures. Because what we know is that aggression escalates. So we want to catch it when the person's impatient, when they're irritable, not when they've drawn the knife. So that could be non-clinical staff, so the admin clerks, the porters, any security that's dangling around. They should all be watching and have a protocol that if they pick up that a person is agitated in the queue, it's a little bit disruptive, or any difficult behavior, any abnormal kind of behavior that doesn't look, is not contained, that they immediately alert the nurses in charge of that unit and draw the attention to one of the doctors. And then somebody could be allocated a position to go to that person for immediate containment. Okay, so this doesn't have to be a highly qualified person. So I've suggested auxiliary nurses, a staff nurse. Obviously a doctor can do it, but if they're often busy with other procedures and other activities. And the goal of this is to go up to the person very, very gently and find out if they're okay, if there's anything that we can do for them. And to validate any concerns that they might have. Okay. So ask them how they're feeling. You could just say, I notice you seem a little distressed. Is it all right? And the idea then is to attend to the needs that they express. So you don't tell the person what to do. You ask them what is worrying them. What attention do they need? So in that example that I gave, then the needles in the hand was the need, whether they were there or not. Okay, so that in a busy clinic, it's very difficult, but you would have to actually ask them, what is it that's worrying them about it? And speak to them about it, not confront the delusion, not say to them, but there's nothing there. Attend to their physical health and their physical comfort. So again, especially if you've got psychotic people or anyone else, or somebody who's a substance using or a delirious person, obviously needs physical health, but we often think the problem is the mental illness, so you want to attend immediately to the mental illness. But the person might be concerned with something else. And it's a way of showing attention. It's a way of showing care. So even if you say to them, sure, I'm just really worried, you seem a little clammy, let me do your blood pressure, let me take your pulse. Are you feeling okay? You're already showing concern for their welfare. And this is very important in terms of soothing and containment. And then finally, start focusing in on whatever the mental illness is. Okay. So to de-escalate, these are the points that are in the STG: be calm, confident, kind. You talk softly, gently, reassuringly. You explain whatever you do, no surprise movements or instructions. You drop your shoulders, you open your hand, don't clench your fist. You might see that the person's got a clenched fist, and that's something to look for even while they're sitting in the queue. Somebody who's sitting there clenching their fist would be somebody an auxiliary nurse could go up to. Open hands, very important. Don't make direct eye contact, that's challenging. So you talk and you look at the person's mouth rather than into their eyes. Never turn your back on a patient. So I would say don't turn your back on any patient. Don't attempt to reason with the patient. Okay, so unreasonable demand, angry, needles in his hand, they've left the metal in his hand, you don't reason. Done the x-ray, they're not there, shame, but you're still very concerned about it. I can see it's worrying you still. And the problem is it's time consuming. Don't argue, don't confront delusions, and don't reach out to touch the patient. So even if they're distressed and tearful, be very wary of touching them if there's any agitation, because that's into their space and they might retaliate. Okay, you've got to set clear limits, and we'll talk about this just now. But you've got to do it in this very gentle, very calm way, and then guide them into a quieter, calm area. So away from the massive queue of patients, and you don't want to leave them unobserved. So this is just 10 domains. I'm highlighting this again because I think what we don't really understand is the importance of de-escalation. We want to take control and fix the problem. This is unbelievably important, the de-escalation phase, and you can mitigate so many problems if this is done properly. So this is just taken, and I'll send this article through as well. Okay. Again, you can just see the same things, okay? Recognize their needs and feelings, always validate their concerns, even if it's bizarre, okay? And you pay close attention to what they're saying, and you never lie to them. So you don't promise something you can't do, okay? You rather circumvent the problem in some soothing way, okay? And again, you've got to set your clear and definite boundaries. So ideas of how to phrase things is, you seem upset, you seem angry, you seem distressed. Please tell us what the problem is, okay? Or would you like to? Can you tell me about it? If you're finding them too much, you could say, I really want to listen and I want to understand, but I'm feeling frightened. Would you mind sitting down? Okay. You now need to try and admit them. They don't want to be. And so again, speak to their need for safety rather than their need for treatment. Okay. So I understand that an admission is uncomfortable, but this is the safest place that we can keep you. Okay. So those are just ideas of how to phrase yourself with the person. Okay, so if we go on to making your emergency assessment, you're doing this actually all the time while you're de-escalating. In fact, the very moment somebody says to you, I'm a bit concerned about that guy over there, you start making your emergency assessment. So your first step is to determine if the person is at imminent risk of harm to self or others. So you will be asking over the scenario of their presentation and the person that is there. If you want to know if you're dealing with a special population, is it a pregnant woman? Is the person elderly? Do they seem to have intellectual disability? And then you're running through your mind what could be the differential. Is it a physical health condition, substance use, psychological problem, or psychiatric disorder? So if somebody says, well, the person was brought in by the SAPS, and you should have a Form 22, or the family have brought him in screaming and kicking, you already know that there's a whole backstory of aggression and violent or abnormal behavior. Okay. And those could be under the influence of alcohol or drugs, or it could be somebody who's coming in and you can just smell the alcohol off them, or you've got this whole, the eyes are bloodshot and you think that they're using substances. So you go to that person knowing already that you're going to have to really work hard at this calming. The high-risk person is more difficult to know, okay, because that is that pre-existing knowledge, which we hope is there in the nursing staff. So have they ever been aggressive before? Okay, is there any history of them using a weapon or verbalizing an intent to harm? So if they haven't actually hit somebody, but they have used aggressive language, any history of swearing and carrying on in a casualty. History of substance use. If there's no pre-existing psych history, it might actually be worse, because you're thinking, am I dealing with a delirium? Is it a head injury? Well, what else is going on? And the same thing if there's a pre-existing medical condition. Special populations, so pregnant women, or if they're postpartum, be very, very concerned. Obviously, they could be in labor. They could have a delirium, secondary to obstetric complications, sepsis, or organ failure. Always think of your patients as being victims of some or other assault. Wondering what substance use they have, and if there is a mental disorder. And the mental disorder might be an acute stress disorder, a brief psychotic disorder, or it could be something like schizophrenia or mania. The elderly, again, delirium. So delirium comes first with everything. Okay, but your suspicion of delirium is going to be very high in the elderly or people with intellectual disability as well. Okay, is there dementia in the elderly? Often they're victims of abuse. And I've actually, we had a patient where I found a case series on this. She actually had severe PTSD from abuse in the home. And she was admitted as being floridly psychotic and very aggressive and quite delirious. And it was actually all the trauma that was creating this disorientation. And so it was the trauma on top of a dementia, creating the sense of delirium and the disruptive behavior. Intellectual disability, the biggest problem with people with intellectual disability is that they often cannot express or explain their distress. So very often if they're anxious, it might come across as aggression. The other problem with intellectual disability is your reasoning. And our problem is often with mild intellectual disability or even borderline intellectual functioning. So your reasoning ability is much less. Their ability to manage emotions is much less, or maybe impaired. So you really have to be very gentle and very difficult not to, and very cautious to confront them. You want to try and always keep them and validate and let them feel intact and dignified. It might be very sensitive to being put down. Okay. The differential diagnosis, this is in the STG. So physical health conditions always, even in somebody who's got a well-known mental illness, you still think of a physical health condition. So people with mental illness more likely to be assaulted than the general population, more likely to get head injuries than the general population, and actually more likely to get medical illnesses than the general population. So you've got to, you can't just say, oh, it's that guy again, he's got schizophrenia. Every single time you've got to check out at least physical examination for a physical health condition. The substance misuse, again, could be somebody who's got no psychiatric disorder other than the substance use disorder, or it could be somebody with a personality disorder or somebody with bipolar or schizophrenia, and it's going to make things much worse. The psychological factors, what makes it very difficult is the high levels of impulsivity and antagonism, but very importantly, the hypersensitivity to rejection or insult in somebody who's got quite narcissistic traits, or anybody who feels severely inadequate will feel persecuted no matter what you say. So it's always again about smoothing over and being sensitive to how they feel and their ego, basically. And then the psychiatric conditions. And I think autistic spectrum disorder needs a special mention. We don't often think of it. And they can be extremely aggressive and incredibly violent. They often cannot tolerate, so they get more violent the more you try to contain them sometimes. And the need for calm and space is absolutely huge. If they're stuck in a noise and a noisy casualty, it might escalate their aggression. The difficulty in communication exacerbates this, and their difficulty in understanding social behavior. So they don't know what you're trying to explain. They might misread your gestures. So everything's got to be very simple. No three-stage commands, all very simple, very concrete, what you say all the time. The other thing with autistic spectrum disorders, if you do suspect it, it might not be the right thing to admit the person, because that might escalate violence even more, because they simply cannot tolerate it. The whole way we manage people with autistic spectrum disorders is the environment has got to accommodate the person. So getting back history, getting collateral history is extremely important. And trying to work out what else you can do with that person is really important. Okay, so as you make that, you make this assessment, and it's all happening simultaneously, the de-escalation, trying to work out what's going on, and then you're trying to think, how am I going to tranquilize this person? So when we prepare for rapid tranquilization, and this should all obviously be ready beforehand, it's in your triage, in the protocol, in your unit. Just keep in mind that your objective is not actually to sedate the person into oblivion. You can do that once you know exactly what's going on. But the purpose of rapid tranquilization is to help to contain and calm that person, to minimize the risk to themselves and others, and then to be able to make a clinical assessment and manage any underlying conditions. So we don't want to use restraint as much as possible, but sometimes we do have to use manual restraint to administer medication. It's got to be respectful, it must be kept to a minimum, and it should be applied by the personnel who is of the same sex as the patient. Mechanical restraint, tying the person down, is only if absolutely necessary. And I think the guidelines don't want it for more than 30 minutes, although sometimes we do have to do it for longer. Okay. You need probably at least 6 people to restrain a person appropriately, to do it gently. It's more likely that you're going to have injuries and assault if you don't have enough people. So this is where your security backup and should be trained so that if it's necessary to do this before you can give medication, they can come down and they know exactly what to do. Calm, collected, synchronous. Very often, as soon as you've got a couple of big security guys, the patient will calm down. They will relax and allow you to inject them. So very often you don't actually have to pull them down and restrain them. And it's all about moving in with that air of confidence, with the air of control. And then just a note on pregnant women, you obviously want to really avoid restraint where possible. But if they have to be restrained, try whenever possible to keep them in a semi-seated position, so not supine prone. Just again, from the same article, just to bear in mind that mechanical restraint can have very serious consequences. So I know of one patient, this person was kept in the emergency department for over 72 hours strapped to a stretcher because there's no beds. And she shot a pulmonary embolus and died. She had actually been in the ED a couple of weeks before, also strapped to a stretcher then. So we don't know when she might have developed the DVT. So there's obvious physical consequences and health consequences from mechanical restraint. I know of another young guy who was actually killed in a ward from being restrained aggressively. He had quite severe intellectual disability, marked behavioral disturbance, and I think he probably had an autistic spectrum disorder. And the problem with that is because they get so ballistic in their rage is the staff apply more and more force. And this is what you can't do. You've actually got to stop and think, hold on a second, what are we trying to do here? Does this guy, would it be actually better to even try and do this as an outpatient, manage this guy as an outpatient rather than admit? The other problems, the feelings of humiliation, the loss of trust in self, reduced adherence to treatment, decreased self-esteem, and even PTSD. These are happen quite often, actually. So I work in a community setting and we offer a service on PHC clinics. So it's an ambulatory setting. So I'll often have guys who have been in through the hospitals, but up to Sterkfontein or a psych hospital and then out and back. And when I inquire about the admissions, they usually can't tell me anything at all except for the security pinning them down and the restraint. They've often got no idea of what was really wrong and what their diagnosis or treatment was. But this sticks in their minds. So it's not the goal. It is necessary, especially in our context in South Africa. We're very far from not doing this, but you've got to keep this in mind when you're managing these patients. Okay. Sorry, this has covered it. So this is again taken straight from the STG. So the first step in your medicine treatment is to offer an oral benzo. And you can offer them whatever you stock in your clinic or hospital. Just bear in mind that midazolam is ultra short acting. So you could use the vial. I think this is, and they can swallow it. It works very rapidly, but the effect may be worn off after about 3 hours. Lorazepam is intermediate. Most of us don't have it in the public sector because it needs a fridge, and it's not always the supply isn't reliable. So generally speaking, in my hospitals, we use diazepam or clonazepam oral. Clonazepam, and both are long-acting. The diazepam has more accumulation than the clonazepam. The idea is to allow time for the oral medication to take effect, but you can repeat the dose after half an hour. Obviously, you repeat your long-acting ones less frequently or with less enthusiasm, and you might start with a low dose and repeat with a low dose rather than giving them a high dose, unless you know that this is a patient who is frequently coming in with aggression. Okay. The next step is to proceed to parenteral, to injectable antipsychotics. Okay. If you know that it's a person who is clearly psychotic and you're absolutely sure this is not a delirium, you can give the antipsychotic straight off. You don't have to use the benzo first. And the antipsychotic might be more effective if it is clearly caused by psychosis. We don't have haloperidol IM. So, and this is a national issue. It's because the pharmaceutical company has stopped manufacturing it in South Africa, and we're not able to get another manufacturer or supplier. We are reviewing the medication for intramuscular rapid sedation. But in the meantime, what we do have is clothiopine, or etomine is the trade name. So just make sure that your units do have a vial of etomine. It comes as a 40 milligrams per mil. You don't need to use promethazine with it. It's got antihistaminic side effects. It's got anticholinergic effects. Its side effect is mostly cardiovascular rather than neurological. So it's more of a problem in the elderly than in children and adolescents and the youth. And your dosage, you would start with 20 to 40 milligrams, using the higher dose in young people, the lower dose in elderly. And you can repeat that after 30 minutes or so, or 60 minutes if needed. The pixel actifase, euclopentixyl acetate, you would only use if you know this is a psychiatric user. This is somebody who's got schizophrenia or bipolar disorder. It's somebody who's had neuroleptics before. And the reason for that is once you've given that injection, it's fairly long acting in that it stays in the system for 72 hours. So if they develop a neuroleptic malignant syndrome, you can't just stop your medication. And that is the dangerous aspect of this. But if they're not neuroleptic naive, if they've had them before, and the advantage of giving euclopentixyl acetate is that you then don't have to give them 3 times a day injections. You've got an injection which is going to last you 2 to 3 days. Okay. And then we just caution to add thiamine oral 300 milligrams daily if you suspect alcohol use, for what it's worth. Okay. Always monitor the patient afterwards, and you nursing them in the recovery position. So if they continue to be restrained, that's also in the recovery position. You really have to monitor the vital signs. The quieter they are, the more likely they are to be dead. So you just don't think, oh, thank goodness he's quiet. Unfortunately, that's not how it works. Pregnant women, remember to monitor the fetal heart rate as well as the mother's vital signs. And then as the person starts to come around and wake up, you continue your monitoring and your observation, because now they may have falls, they may now be delirious from the sedation, and they may have paradoxical reactions, and this is often when they abscond as well. Okay. If you can download if you've got the STGs on an app, it's quite nice in the sense that you can quickly go to the other sections. You just click on the link in the app and it goes immediately to the other sections, which tell you how to manage any of the adverse effects that you might get. So just in summary, if the person is brought in, you want to know firstly if the person's brought in by the SAPS or family or neighbor or somebody else. If it's by the SAPS, they should have filled in a form 22. And all that form does is it describes the circumstances in which they found the person. And the casualty must complete a form 1, okay, which is an emergency admission for 24 hours without consent, because the person is deemed to be very dangerous to themselves, and your reasoning is that they needed the police to bring them in. If they're brought in more calmly or by family or neighbor, then get them to fill in the form 4 while they're there. Don't let them disappear. They cannot dump and run. Okay, and we'll go through that a little bit just now. Well, or we can do it now actually. So I don't know if you all understand what the form 4 is, but it's the application for admission. And the new form 4, they have an application for admission and they've got to explain why they want their relative, neighbor, friend, associate to be admitted. Now, if they're not there and you're a healthcare provider filling in that form, you've got to explain what efforts you have taken to trace the family to fill in the form 4. And so that's why I say you try not to let them dump and run, and you try and catch them. The other reason for trying to catch them is the collateral history, obviously, but also because these problems are very often related to issues in the family, high levels of expressed emotion, very poor interpersonal skills in the family. And it can sometimes help considerably to have the family there, and if somebody can be actually working with the family. So that's another situation which I remember we had recently. We had a guy who, how he got there, I don't know. He drove himself. He was to the clinic, and we wanted to get him to hospital. Unbelievably hostile, extremely psychotic. And so we started to fill in the form 4. Now we had to contact the family to trace them. Eventually the family came in, and we had the police and the EMS there to take him to hospital. We ended up having to turn them away, and he went home with his family in the end. So it can be very well worthwhile having them there and spending the time in trying to work out what's been going on. He was still psychotic when he went home, but he took his medication, and we had a plan of action developed. So that can be very helpful, as well as trying to transmit some skills. When they see how you de-escalate the person, they might learn the same skills. Okay. Your first question: is the person alert? Have they got a clear consciousness? Are they medically stable? Okay. Are they orientated? But otherwise you manage as delirium. Okay, and that clicks onto chapter 20. It's in the emergencies chapter, but we have got a circular as well, which we put out because haloperidol wasn't in stock. And most of your management of delirium is actually non-pharmacological and managing the underlying condition. You may, though, use clothiopine as well. Okay, if they are, you de-escalate, contain. Are they contained and cooperative? If they are, you manage their main complaint. You offer oral sedation. Are they still cooperative, but require admission? You admit them then, possibly as an assisted user, maybe for 72 hours observation, depending on how volatile you think they are. Okay. If they're not remaining cooperative, then it's definitely an involuntary admission. Okay, and obviously here. So the point of this is that it's all about repeated reevaluation. It's about contacting relatives if you haven't spoken to them, and then repeated reevaluation of the mental state, detoxification from any substances, and then initiating treatment for the psychiatric and medical condition. So this is essentially what you do in your first 3 days. It's a 72-hour observation if they're admitted as an involuntary user. Otherwise, it's just an acute admission. And this is what is not clear. See, people seem to think they're all admitted to 72 hours. And then you can dispatch the person, either that's discharged, further inpatient care. You don't have to wait for 72 hours to be up if the behavior is so hostile and beyond the facility that you are working in. You can transfer to a psychiatric hospital with a Form 11 and all your investigation results, and they'll probably want everything under the sun before the 72 hours is up. The biggest reason why we don't do that is that there's no beds in the psychiatric hospitals. So you're very often forced to keep them, and this would be the situation you're going to use Clopix or Accuphase, and you may have to use restraints intermittently. Okay, so just the last note on the Mental Health Care Act. So just to remember what the purpose of this Mental Health Care Act is, and unfortunately people interpret it as governing the admission procedure. But actually, what it is to ensure human rights-based care. So respect human dignity and privacy, as highlighted in Section 8 of the Mental Health Care Act. And this is what one has to keep in mind, no matter how difficult, how provocative, how obnoxious the patient may seem. Okay. Our job as healthcare practitioners is to understand that and to address it, no different to how you might manage somebody who's got a severe cardiomyopathy and cardiac failure. It's palliative care in that situation, but your job is not to try and fix everything, but to understand the patient. And your skill is giving them respect, human dignity, and privacy, even in this situation. Okay. And then part of what the regulations are, so Section 9 is all about what to do if they cannot consent. And you feel the need to admit them. So the purpose of the Form 4 is the application by somebody else to have their relative, friend, or their ward, if they're a guardian, or if they're a social worker, admitted into hospital. They've got to explain why they're applying for it. And it can only be used if the reason for not wanting to be in hospital or not being able to understand the purpose of the admission is due to the mental illness. So it can't be used in delirium, which is not actually a mental illness per se, it's due to physical illness. And it can only be used with a delay in providing care would result in the death or irreversible harm to the health of the user. So that would be your emergency admission with a Form 1. If you don't know what's going on and you know you've got to get them in. Otherwise, you've got the Form 4 and the Form 5s if people are there. If the user may inflict serious harm to himself or herself or others, or cause serious damage to or loss of property belonging to him or her or others. And that includes financial indiscretion in somebody with mania. So this is really this is your reasoning for an involuntary admission. Otherwise, the assisted admission is used when you've got somebody often with intellectual disability who isn't, or with cognitive decline, who isn't actively refusing treatment. They don't actually need to be completely dangerous, but you feel that they are at risk of harm, okay, if they're left untreated. And then you would do your assisted admission. And otherwise, you must do a voluntary admission. The difficulty with voluntary admissions, you might think that they've, and this is again something that I've experienced, because we've been trying to be person-centered, and you do a voluntary admission and somebody who's got bipolar disorder, get them into hospital, and the next thing is they refuse hospital treatment, sign an RHT and go. So if they're admitted under the Mental Health Care Act as an involuntary, they cannot sign an RHT. What they have to do is appeal to the Mental Health Review Board, and that appeal must be lodged within a month of the admission and heard immediately by the review board. So this is the Townhill Hospital website, and I just think what they've done here is really, really nice. And so I put this on here and sending you the link, because what they've got is all these forms, everything except for the Form 48, which is the restraint register, and then the forms for abscondment, and which is notifying the police to go and collect somebody who's absconded from hospital, who's there as an involuntary user. But what they have is this example, and it's well worth clicking through these and see how to fill in these forms. And they've got the example of the Form 4, if it's done by the relative, and if it's done by the healthcare provider, of the Form 4 by a medical practitioner or by a professional nurse. So with the Form 5, there's 2 Form 5s, only one needs to be done by a medical practitioner. It's got one of the Form 5s must be done by somebody who's qualified to do a physical examination. So that's just a very useful website to go through and to have a look at the forms that they've got. So thank you very much. And I see there's some comments on the chat. So I hope we've got time for some discussion. I'm going to stop sharing and open up for any questions.
Thank you very much. No, we definitely have some time for questions or discussion. And I think I'm also happy to open it for questions that are slightly wider than just the topic, because I know mental health is a challenge for our doctors in those rural facilities with very little access to psychiatry advice. So I'm quite happy to open that. People can either put questions in the chat, or you can just unmute yourselves, or you can put a hand up.
So I also would like to know, I mean, I wasn't quite sure how much you all know, and you're all doing ComServe, I assume, not internship.
Wide variety, actually. We have from ComServe,
okay,
experienced doctors,
okay,
all joining. Yes.
Okay. So, you know, Madeleine, you can give me feedback if you're doing this again, and if we need to change it slightly as well.
We'll do a little poll in a minute as well. That will give us a clue.
Yeah.
Let me run the poll while people are thinking. Oh, there is a question, Prof.
Yeah, you can definitely give benzos IV. So, in fact, diazepam or clonazepam, you can give IV. I'm not actually sure about etamine, quite honestly. We often then do need a lot of manual to do that. But if you can get somebody to hold the arm down and you need to give it IV, without a doubt, you can do that.
Just seeing if there's more questions. I have it's slightly unrelated to the actual topic, but it's one of the challenges we've had in terms of referring your patients on to psychiatry. And in our area, what's become a bit of a gatekeeping between us and being able to refer is, of course, we do the full delirium workup, is vitamin B12. So I find if we were to do randomly vitamin B12 levels on most of our patients, that everybody seems to be running a little bit low. I don't think people are eating properly. And then what ends up happening is you'll have your patient, you'll do all your bloods, everything's normal, but the B12 is under 200 is the magic number for some reason in our area, even though it's not below the lowest level of normal. And then the challenge is quite often we are told that we need to first correct the B12 before we can refer on to psychiatry. And I was just wondering about the incidence of how much B12 actually contributes to psychiatric illness.
So, I mean, obviously you can have a, you can have some neuropsychiatric presentations of a megaloblastic anemia. But I must admit, okay, so these are difficult issues, and they're thorny issues because I don't think that a B12 is going to contribute to such severe delirium. But I don't know, you would have to find out why you've got, I mean, it's not just going to be a low B12, you've got to have a full-blown megaloblastic anemia, a raised ESR, CRP, a low HB, a raised MCV, and the typical neuropsychiatric signs of a megaloblastic anemia that goes with that. So that is a bit of a, if it's just one isolated level, it's very arbitrary.
Yeah, I think
it's not.
I think it's useful to know that the neuropsychiatric effect is related to the megaloblastic anemia, because that gives one a reference point where you can say, okay, the B12 is low, that's at risk, but because they don't actually have any anemia, we're not concerned that this might be a main contributor to the psychosis. So I think that's very helpful. I'll go and do some research as well, but I was just thinking in terms of your experience, can we stop blaming?
Yeah, I mean, I'm actually having to think back to myself at doing medical. I was a normal doctor for many years. So, and we obviously treated the people with megaloblastic anemia in a medical ward, and they had some neuropsychiatric stuff, but it's not florid and absolute psychosis. You know, so
yeah.
But I know these arguments come up, and they can be extremely difficult to negotiate. But I would check and say I would actually look up what the neuropsychiatric problems are with low B12 and with and what else should be there.
I think there's another comment in the chat.
Okay.
So the question is, how do we deal with relatives
how
that
do we
are
deal with them?
on their relatives?
Yes.
So when the relatives wants admission, but you're not convinced that.
Yep. Okay. So I mean, it's actually a problem because they are possibly more uncontrollable when they're at home than when they're in hospital. Okay. So we discharge them to homes which can't contain them for a whole host of reasons. Okay. And I don't find that our social workers are really trained to support the families adequately, because they need, you really need a lot of family intervention, teaching them what the disease is. We should be doing psychoeducation of the patient and of the family. And it's a very recent publication, is on schizophrenia and the length of relapse and readmission in relation to family engagement. And they found that family engagement reduces relapse and readmission, but not if it's only sort of 1 to 2 hours of psychoeducation. So a one-off meeting and just a quick explanation isn't likely to make a difference. And this is the problem that we've got. We don't have a health system where you bring the family in repeatedly in an ambulatory setting, where you're teaching them about what bipolar is, how to manage the substance use, or but in particular, how to talk to each other. You know, how to talk in a respectful way, how not to belittle the person who might be the slow learner in the family, how to greet each other in the morning, how to be present for each other, and how to be present for the person who's difficult. So it can be really complex. And this is a major problem that we've got. So the problem is that we might think the person's not eligible. The relatives have a different idea because the person can be extremely difficult. They're provoking each other, and it's in a vicious cycle. And it's very hard to make a statement that he's not eligible for placement. I think it's something to work with the social workers and to find out what facilities are available, what NGOs, what NPOs, which are not registered with the health system, are available. What does DSD know about? And then to ask the social workers if they are in a position to, say, do 6 to 8 weeks of counseling with the family on how to manage people who are quite difficult in the family. So that's non-Dumisa is not very helpful answer, and it's because we don't have an adequate system for this. I don't know if anybody else has a comment on that or what they've done.
Thank you very much. I think it's one of those ones that each scenario is always slightly different, so it's sometimes not so easy.
I think it's very important to try and schedule meetings with the family if you can, and you schedule them so that you've got at least half an hour with them. And each time you ask them, well, how's it going? And you have hit the user with them as well. So you've tried to do a bit of family counseling. But one of the tricks that I learned in psychotherapy is to, if they're talking amongst each other, you ask one family member how they think X or Y feels when their brother says such and such. So say a brother says something and you can hear, sure, that sounds a bit dismissive. So then you ask the sister, well, how do you think the other brother, who's the patient, feels when his older brother says that? Or even if there's only two of them, you know, how do you think your son feels when you get quite angry with him like that? Because we don't think in our families, we speak without conscious awareness of how the person feels when we speak to them. We often joke in our families about somebody. We have quite nasty teasing that goes on, and we think, okay, it's fine, we're just teasing, and we're unaware of their sensitivity to it. So it's trying to bring that conscious awareness into play with the family, so that it's not a blame game, but everyone's aware of it, including the person with the condition, who's how does his father feel when he screams back at him? Does he think that that's an effective way of telling him how he, the user, is feeling? Has he ever thought of trying to explain his feelings in another way? Another thing to do is, same thing with the de-escalation. When they're sort of angry, you could say, sure, I can hear you felt really hurt by that situation. Not, you know what, it wasn't actually a serious situation, you need to get over it. Okay, I can hear you felt really hurt when your father got angry with you. And we're seeing this in we've got a massive generation gap in our rural populations, in our township populations. The young kids are often very sophisticated, and sometimes their parents or grandparents that they're living with might hardly be able to read or write. And it's incredibly difficult for them to discipline them. They may be using traditional sort of ways and methods, which the young kids are rebelling against, and they can't handle the cheek that they're getting. So it's often about very simple stuff like that. Okay, a serious problem of SAPS dumping. Okay, so that I would go to your institution head or your clinical manager in your institution. Okay, and get the management to try and get the SAPS in to engage with them. Okay, it's incredibly difficult. The SAPS actually are very often extremely exasperated with people with mental illness. And I think, personally, I think it's a problem with the legislation. I think they feel that these are not criminals. Their training is to deal with people with criminal behavior. These are people who are sick. And this is information I've had from the SAPS members themselves. They're often very afraid of being accused of assaulting them, of human rights violations if they're too strong with the patient, because these are not criminals, they are unwell. And just as we don't know what they are when they come in, they're completely undifferentiated problems. They may have a history of psychosis, and they may have a history of substance use, and every substance user may be cardiovascularly unstable. So they are often fearful of this, because they were fearful of being accused of brutality and police brutality with these patients. So there may be issues like that. So again, if you can get a meeting with them, it's about finding out what is their perspective and how would they like to go about these patients. And in my district, there's an arrangement between the SAPS and the emergency medical services. And it's a huge process because both have to be present. The family might call the SAPS to go in, and they do bring them in, but I think we probably have a similar situation of dumping and running when they bring them in alone. But I think it's worth meeting with them and finding out. And if they don't want to, we need this feedback to get up to national. So there is a national directorate, and feedback needs to go to the National Department of Health that this system isn't working. And it isn't. I find the whole legislation's not, I shouldn't, this is going on YouTube, but I think in many instances it's compromised. Even having all the forms, I've gone for 18 months, we had no toner in the district. So the SAPS might be feeling, why should they fill in all these forms? Why should they keep the forms? Why should they print the forms? It's their stationery budget that they're using. They're probably also running out of toner all the time. So it's about finding out all of those kinds of issues. What is their perspective, and giving feedback to national around this. And then trying to get a working relationship. But that'll come more easily if you understand their perspective.
Thank you very much. And I think there's lots of polls there. I also love all the examples. I can hear you've had many years of finding exactly that right tone of voice to help de-escalate. And those examples have been very, very helpful. Thank you so much again, Prof Robertson. I'm hoping we can call again on you in the future to cover some more mental health topics for us on the rural health webinar networks, because this is an area that's very, very sorely neglected. So even if you go out and look for resources and webinars on mental health topics, there's actually very little out there for your average frontline clinician. So we would love to use you again in the future if that's possible.
With pleasure, Madeleine.
And then I'm just going to say good night to everybody. Thank you so much for joining us for the last 6 weeks. I'll be sending out the last resource packs over the next couple of days, and then I'll be sending out some survey forms as well to see how it was and what we can do different and what we can add. Prof Robertson, just for quick feedback, yes, so more than 80% of the group found it very useful and the rest useful. So it's definitely hit exactly the right spot. And I think it's been very beneficial. And we do find that more people actually watch these webinars afterwards than on the evening. So when they find time in between calls and things, and it will be available again for tomorrow for all our frontline doctors. So thank you very much, and good night, everybody.
Thank you, and good night.